So good morning, everybody. So in this very good Sunday morning, I hope you all are ready for all some interesting cases which we do have to discuss, and we have lots of time to discuss with these cases. So basically we are going to deal with some cases. It may not be completely neurophthal or completely pediatric. We have a potpourri of all kind of cases, and we do want to have a two-way discussion. Let it not be a one-way discussion. Okay. So first of all, I would like to invite Dr. Nirmal. He is a senior consultant, pediatric ophthalmologist. So his case is don't blink, you will miss it.
Thank you, Soumya ma'am. Thank you, KSOS, for giving the opportunity. I am going to talk about a scenario which most of us would be coming across, which is a child with frequent blinking. Okay. The main problem when it comes to examining such children is to get a proper slit lamp examination, especially if the child is very small, apprehensive, it becomes difficult. So the highlight of this case is to listen very closely to the history. Okay. So here we have a 3-year-old girl who has paroxysmal episodes of eye blinking for the last 3 weeks. So the history is like the child starts blinking forcefully, intermittently for some time, and it gradually comes down. It may last for half an hour to 1 hour, or it may go on for a couple of hours, and then gradually it comes down. So by the time they reached us, multiple ophthalmology consultations were done with lubricant eye drops, antibiotic eye drops. Everything had been tried, but the condition persisted. And finally, the last person who saw suspected seizures and referred the child to the pediatric neurologist. So the pediatric neurology perspective, our consultant was suspecting either G1 syndrome, which is an epilepsy with eyelid myoclonia, or a sunflower syndrome. Sunflower syndrome, though rare, it is usually seen when the child goes out into the sun and they have a peculiar hand movement across the face. So that is typical of sunflower syndrome. But somehow our pediatric neurologist was not convinced regarding these paroxysms being seizures, and hence was referred to our department. So when we revisited the history, we came to know that there was a history of trauma with a toy, plastic toy, to the left eye a few weeks prior to the onset of these paroxysm of frequent eye blinking. It was treated in a nearby clinic and she was relieved of the redness photophobia in a couple of days' time. Now, when I kept listening to the mother, because most of the time mothers are somehow, while history taking, they seem to be better clinicians than us. So when I kept listening to her, she gave the most important clue and she said, "Sir, this happens most of the time, this happens when she wakes up from her sleep." So that was the major catch in this. So the examination part was quite difficult because the child had already had consultations. It was very apprehensive. All, the routine pediatric ophthalmology, shouting, screaming, everything was happening. But somehow we could do a slit lamp examination. The other evaluations were all normal, except there was a small nebular opacity in the nasal left cornea. There was no refractive error also, and the fundus was normal. So this was how the child was behaving. This is after she wakes up. She keeps doing this for quite some time and then gradually starts opening the eyes. So if you are listening, she is actually telling her mother not to take video. So that is what prompted the neurologist to think this is not a seizure, because the child is well oriented, conscious, responding to everything. So a provisional diagnosis of a recurrent corneal erosion in the left eye was made. And all we did was to give lubricant eye gel and specifically instructed the mother to put it before every time the child goes to sleep. And otherwise the eye was quiet. When I saw the child, there was no redness, no photophobia, no lacrimation, nothing. It was a quiet looking eye. So all we did was give the lubricant eye gel every time the child goes to sleep. And when we reviewed after 1 week, there were no such paroxysms in that 1 week. And so we continued the same for a couple of months and the child became symptom free. So these are the differential diagnosis. First and foremost, definitely we need to rule out any refractive error no matter what the age of the child is. The second most commonly we encounter is the allergic conjunctivitis. Now tics are becoming more and more common in our clinical practice, where the child comes with frequent forceful blinking of the eyes, and most of them have associated conditions like ADHD also. And intermittent exotropia is like it is closing one eye. The other differential diagnoses are not that close. Then we have the rare causes like the hemifacial spasms and such things. So my take home message is always listen to the history, and most importantly in this case it was happening every time after the child woke up from the sleep. Thank you.
Thank you, Dr. Nirmal, for for an eye opener. Actually, even though the child was closing the eyes, it's an opening for the ophthalmologist. And I think that is. Should we leave the discussion to the end, or we can have it as an. So especially in a recurrent corneal erosion, I myself am a personal. I have a personal experience with recurrent corneal erosion. I had recurrent corneal erosion in my left eye, and I had it for around 5 years.
Okay.
So it is very painful, and unfortunately when you see the patient at 10 a.m. in the morning, nothing will be seen most often. So a video is very valuable in most of these cases, I feel. And even in facial tics, it's very important to have a video. So even if we refer to the pediatrician, I usually advise the parent to take a video and then show it to them, even if they don't we don't see it very often. Sometimes we don't see that patient having that problem during our examination. So it's an eye opener.
No, many a times what happens is when the pediatric ophthalmologist, when they don't get the diagnosis, they end up doing an EEG. The EEG might sometimes come up with something and the child is started on anti-epileptics. So I think the history part is very crucial, and we live in a time period where we are more taught to talk more and listen less. I guess when it comes to our specialty, we need to
Yes,
listen more.
exactly. Yes.
So I have a question. Do we have to send to pediatric neurologist in all the cases if no other factors are there? Like no other right?
Usually what I do is most of them will be having some element of allergic conjunctivitis.
Yeah, we treat
So
that, but
usually,
if still it's persisting, do we have to send all to neurology evaluation? Or
if I am suspecting tics, actually usually I send, because it might lead behavioral therapy, and especially when we are suspecting tics, it is always better to ask for vocal tics also. So that could be pointing towards Tourette syndrome. So nowadays tics is becoming more and more common, and sometimes they have this eye rolling movements. That is what the parents say. He's doing like this, like that, and all sometimes. So if at all I don't find any cause as such, and if I feel it is tics, then I send for a consultation.
I totally agree with
One more thing I want to tell. I am one of the older generation ophthalmologists. The history is very important. What you said is very good, which is lacking nowadays. Many people don't take a proper history. So a proper history from a very good observer, especially the mother, in case of children, is very important. That is one point you have struck.
Mother, sometimes it is made nowadays.
Yeah, who is very
So
observant and
I ask
usually
who is sending maximum time with the child.
yeah, that is very important, and that is one good thing that you have stressed. Very good.
as a pediatric ophthalmologist, we usually don't get a history from the children at all. So, whoever is a bystander or whoever is a caregiver, I think That is one very relevant point, that you need to take a proper history from them and rely on that history also. It's not enough that you take the history, because we are always doubtful whether they saw it correctly or not. Because recently the same kind of a scenario I also had. The child turned out to have autism. And it was they just came with tics and with the just head tremors, and you need to keep observing the child. It may not be only the tics, I mean the blinking that you're seeing. There may be slight head movements or motor movements. So they may be just motor tics. They may present with motor tics, but may have underlying an autism long.
Excess screen time is another important factor nowadays. The children who are watching too much of TV, mobile, they end up developing this frequent blinking, and most of them don't have anything else. And if you ask them to stop for a couple of weeks, most of it dies down. So we can try for a conservative, wait and watch kind of attitude also. We can take maybe maximum for a few weeks or a month at max. But beyond that, if it is persisting, and sometimes what happens, the child has had a recent change of school or change of situation, a close friend has gone to another place, or I have seen such cases also, and they suddenly develop all this tics.
More of a behavioral or stress related response that you see in children. But I think even if you don't have a pediatric neurologist at hand, I know that you have a readily accessible
I have a
pediatric
very good
neurologist.
pediatric
So
neurologist.
if you even if you don't have that, what I feel is a pediatrician who is sensitized to these sort of patients, because everybody may not be sensitized to these aspects. So if it is that is available, then that's also a good option.
Neena ma'am, your comments on this.
Usually, because we are seeing the child for a very short duration of time, and I usually ask the parents to record the eye movement videos at home, because that's a very good thing, because you may pick up some unusual movements in the videos which you may not notice in your OPD. So, as you said rightly, we don't label anything as idiopathic or tics unless you get a neurology opinion. So, you rule out all ocular causes, including, dry eye, other conditions of blepharospasm, allergic eye disease, refractive errors, everything you rule out. And if you're not able to pinpoint it, and the parents are definitely worried, that's why they're coming to you. So we don't brush aside anything as idiopathic unless we get a neurology opinion, because some of the kids would have underlying seizure disorders or some other, conditions, autistic, ADHD, but we are not the ones to diagnose them as such. To get an opinion from a specialist, because definitely what we have to do is we have to treat the patient and not the disease. So what the disease is will unfold as we treat the patient.
Another important thing is many of these a little bit older children will be having allergic rhinitis, and they do all kind of things with their face. Even I am someone with allergic rhinitis, and whenever it is severe, I do all kind of things. My face, I close my eyes like this, do things like this. So many of the time they think the problem is with the eyes, but if you ask a proper history, you will know that it is allergic rhinitis, and when that is treated, all this grimaces will disappear.
So it could be like, that's tics can happen it can be any sort of tics. But then before we say it's just tics and, it is just attention seeking behavior, we must rule out all organic pathology.
Okay, so we'll move on to the next
Yes, ma'am.
case.
Thank you.
I invite Dr. Neena. She is the head of the department, Giridhar Eye Hospital in pediatric ophthalmology, and she is a well-known figure. And she is going to present a case when first impressions deceives, a diagnostic dilemma.
So thank you, Soumya and KSOS, for this opportunity. So this was a case which is really close to my heart, because it saddened me deeply because I diagnosed it. So this was a 17-year-old girl who came to us during the COVID time, her brother had bought her with sudden painless drop in vision in the left eye of 3 days duration. So you can see here she had good vision in the right eye. The left eye vision was only hand movements close to face. Color vision was impaired, could not be checked in the left eye because of the very poor vision. But there was a definite RAPD in the left eye. And everything else was normal. Fundus looked normal. So when you took the history, there was no associated trauma or fever preceding it, no associated floaters or flashes. When we kept on digging and asking her, she said, yeah, she's been having dull headache for the last 3 years, and we think it's due to migraine and exam stress, no other past medical history. So the fundus looked normal to me. It looked normal to me then, and it was normal, I think. Yeah, so when we did the serial investigations, we started with OCT. OCT showed normal RNFL thickness. You can see here the left and right eye are almost okay. Retrospectively looking back, perhaps there was a mild GCL thinning in the left eye. If you compare the absolute values to the right eye, there was a minimal GCL thinning. We didn't think much of it then. We did a visual field of the right eye. Right eye was okay, except for some mild peripheral constriction, which I was sure that if I repeat it, it will come as normal. But since there was an RAPD, definitely there is an optic nerve pathology. So we did a VP. We could do a flash VP because of the poor vision in the left eye. The right eye was normal. In the left eye, there was a prolongation of inter-eye latency between the two eyes with some reduced amplitude in the left eye. That's what we thought. So clear cut. What is this? It's a case of retrobulbar neuritis. 17-year-old girl typically fits into it, right? So the brother was very anxious. She was going to write the exam. So they urged me to give her IVMP that day itself when I explained that this could be a retrobulbar neuritis. But then I strongly always believe that, get an imaging done before giving a high dose steroid. So I insisted on an imaging. And, that came as a shocker to me because the radiologist called me up and he asked me, what are you suspecting here? Because I'm seeing something in the sinus. So this was, you can see how the yellow arrow points to this mass lesion in the posterior ethmoidal sinus, which was eroding the bony walls and extending to the orbit and compressing the left optic nerve at the orbital apex. But what is peculiar is that if you have an orbital apex syndrome, you would expect the other cranial nerves to be involved, right? You would expect some orbital changes, some proptosis, some extraocular motility abnormalities. Nothing of that sort was there. It was just presenting with an optic neuropathy. So the commonest space-occupying lesion with an asymptomatic patient is usually a fungal sinusitis. So this was the differential he gave. Could it be a fungal sinusitis? Could it be allergic, invasive, because it was eroding the bony wall? So he asked me, is she immunocompromised? I said, no, she's a healthy 17-year-old girl. So I decided, I was like confused, and I decided to get an opinion from our ENT colleague. That's when he also said, it looks like fungal sinusitis. I'll do a FES, remove the whole thing and clean her up and give back to you. You can give her IVMP. Because fungal sinusitis can also sometimes produce, if optic neuritis kind of picture. It responds beautifully to IV methylprednisolone. It's not the invasive fungal sinusitis, it's the allergic fungal sinusitis. Okay, so what they usually do is they get a biopsy from the sinus mucosa, and if the sinus mucosa is invaded, it's invasive fungal sinusitis, then you need a Brima along with antifungals. But if the mucosa is not invaded, it is usually allergic, and they give IVMP. But then he called me from the table and said, look, doctor, this is not fungal sinusitis. There is a bony lesion sitting there in the posterior ethmoid. I'm not sure what it is. It doesn't look good. I'll take a biopsy and, I will decompress the optic nerve and give her IVMP, but I don't like it. So that's when we sent for histopathology, came as a shocker, undifferentiated cells, all this, funny looking cells, moderate to strong speckled nuclear positivity, all Greek and Latin to me. But the histopathologist read suspect nut carcinoma. I didn't know what it was. I read about it. 1 month later, she was no PL in that eye. Orbital signs happened. Repeat MRI, residual lesion in the sphenoid. She underwent chemotherapy. They spread to the other side. She became bilaterally blind, and in 5 months later, she developed extensive she underwent accentration eventually, but she succumbed to the disease 5 months later after having extensive skeletal metastasis. So we published this report, but we lost the patient. So anyway, it was like, because that's when I realized that this is nut carcinoma. It's a rare cancer, which is expressed in the normal spermatocytes and also in the ciliary ganglion. And what it does is it has translocations and it activates oncogenic transformation of normal healthy dividing cells. It's a rare invasive squamous carcinoma with a median survival rate of less than 1 year. And it has extensive necrotic metastatic lesions and no standard of treatment known at present. So my key point to consider here would be that always image, because imaging picked up the SOL, and it was the biopsy that was crucial, but histopathology clinched it, and immunohistochemistry, strong positivity, certain markers clinched the diagnosis of nut carcinoma. So keep it in mind, rare things can happen, and retrobulbar optic neuritis is a clinical diagnosis. The cause can be anything.
Thank you, Dr. Neena. It was a very interesting case, and unfortunately, it was very unfortunate for that child as well. But the key message is that whenever you get an RAPD, in any case, and you are suspecting a retrobulbar neuritis or whatsoever, you're not able to see anything. Like as ma'am told, it's better to neuroimage the child, because even in case of an optic neuritis or retrobulbar neuritis, to see how extensive is the lesion, it is important to image the child always. Anything else to add?
I just have one more question. When you have, this is a 17-year-old, I think. So if you have a younger child, OCT, when you check the ganglion cell, do you take an absolute value as some cutoff or something, or because normative data is not available, or you compare with the other eye?
Actually compare with the other eye, because we don't have normative data, but we know that roughly, like let's say if the values are less than 40, 30 or something, I'm talking about only ganglion cell, not IPL complex, it's on the thinner side, and especially if the other eye is higher. But here I didn't think of it in then, but retrospectively, I saw that there was some minimal thinning.
Okay.
Plus GCC, when you can take it as always a baseline, because if suppose not in this case, any other case, when you do a follow-up, you will know whether the GCC, it's getting affected in the other eye also, the normal eye. So it's always a baseline report for us.
Yeah.
Thank you, Dr. Neena. So we'll move on to the next case. We invite Dr. Rashmi Bhaskar.
She's a pediatric ophthalmologist. She's a consultant in Chaitanya Eye Hospital, Trivandrum. She'll be talking on a case, Crossed Paths, Unraveling a Case of Strabismus. Over to you, Dr. Rashmi.
Good morning. Thank you, Dr. Soumya and KSOS for giving me this opportunity. My topic is Crossed Paths, Unraveling a Case of Strabismus. So my case is of a 4-year-old female child who was referred to me from Maldives for squint surgery, deviation of right eye noted since 9 months. As per their parents' history, the child woke up from sleep and suddenly they noticed that the right eye was squinting. There was no history of any fever, any illness, trauma prior to onset of squinting, no history of any long hours of screen time, no complaint of double vision. No other complaints was there for her. They consulted the local hospital. There, the MRI was advised from them, which was normal. They advised patching, but the child was poor complaints with patching. After 9 months, again it was the same picture. So they sent to us for surgery. This was a photograph of her just 1 month prior to coming here. That is after the onset of squinting. And her 1 year back photo was like this. And at 1 year, she was like this. So in clinical examination, vision in the right eye was 1/63, near vision less than N36, left eye 612 parts, improving to 66 parts. She had a right convergent squint with a right hypertropia. There was around 45 prism esotropia as per Krimsky and 10 prism hyper. Extraocular movements were full except for a 2+ inferior oblique overaction in the right eye and 1+ in the left eye. Fundus was like this, showing a mild torsion in both eye, right more than left. So we did a investigation, we dilated, and the retina specialist opinion was taken because no other thing was there to account for the defective vision and sudden onset of squinting. They advised a flash VUP and an FFERG. We sent to the pediatric neurologist. They were not very much happy with the MRI taken from Maldives, so they repeated the MRI, which was normal, and they did the myasthenia workup also, and no other neurological to account for that. We did a flash VEP which showed a amplitude reduction in the right eye as compared to the left eye, which could be explained with the poor vision in that eye. FFERG, right eye showed as cotopic better than photopic, but photopic waves were poor, and left eye it was okay. So we were confused. What was the reason for the acute esotropia in this child? And because there were no other factors to account for it, but sometimes when we see a lot of acute comitant esotropias these days, but there may not be any reasons for that. But in 9 months time, seeing this much dense amblyopia was not very common. We see a lot of acute esotropias, but they develop almost around 612 maybe the probable vision, but 1/60 within a period of 9 months were not very common that we see. And FFERG also, usually the FFERG will be normal in case of amblyopia. Multifocal ERG and pattern ERG can be reduced, but usually FFERG will be normal. So regarding keeping in mind all these factors, I was little reluctant to plan surgery. I wanted to do patching, then plan for surgery, or do surgery, then advise patching, because the child was from Maldives, will not be getting for regular follow-up also. But still, I went on for surgery, and I did a right eye MR resection plus inferior oblique resection and LR resection. And the third postoperative day, the child was okay, vision remaining the same. I gave her the glasses. They wanted to go back within a week. So I gave the glasses, best corrected vision, and advised patching the left eye for 6 hours per day. 3 months back, she came back. Her vision improved to 624 parts N80, and left eye was okay, except for a small hyper in the left eye. And she was good compliance with patching this time. And we are waiting for a follow-up. She will be coming next month for the second follow-up, that is after 3 months. This she came in September. So my question is whether you have encountered such a dense amblyopia within a short span of 9 months.
Possibility is that maybe the child would have had
Pre-existing.
amblyopia, and maybe it was small angle esotropia which would have decompensated in a period of time. That could be one possibility. Otherwise, it's difficult to explain. But maybe you have to follow up with the fundus examination. I think sometimes things might unravel as the child grows.
Yeah, only one follow-up we have got. She'll be coming only in December.
Any neuroimaging was done for this child?
Yeah, neuroimaging was done twice. From Maldives, it was done, which was normal. After coming to Kerala, also they did one more time because the neurologist was not happy with the previous neuroimaging. So they repeated the neuroimaging, and MRI was normal the second time.
With
also.
contrast.
With contrast. Yes. They did a full neurology workup.
What was the refraction for her?
Refraction was plus 0.5 with minus 1.5 cylinder. We did a atropine
Only a
refraction.
cylinder.
Yeah,
Okay.
only cylinder. No,
Was an OCT done for her?
no, OCT was not done.
Yeah, OCT would have been helpful at least to know if there was any pathology, because the full field ERG, which is the dark adapted, not see very well in this. The light adapted responses were flatter.
Yeah.
Yeah, the dark adapted, even you can see
Little
the
bit was
dark adapted also were not good, isn't it?
Yes.
You can see the dark adapted, the top, the A wave is not there. The maximum rod-con response is okay, but
But comparable to the left eye,
Yeah.
the left eye appeared to be okay.
Okay, this is right, that is left. This is light adapted, this is dark adapted, right? But the top wave that's flat, isn't it?
Yeah.
The top is flat.
The right eye.
The right eye, left eye also hardly anything. But maximum rod-con response is there.
She's only 4 years. And
Yeah.
She was under
So was it
pedicloric
under
sedation.
GA or
Sedation, under pedicloric
Yeah,
sedation.
sometimes poor cooperation can also produce this. But if you're suspecting some photoreceptor dystrophy, it's a good idea to repeat it.
Yeah, when she comes for the next visit, we thought we will plan for
Yeah,
big
because
ERG.
yeah, so common conditions which we mistake is retinoschisis, but here the B wave is good in the maximum rod-con response. There is no negative B wave. So all those things we may miss it because we are not doing 90D and all that. Sometimes we may miss all this, but it will be usually hypermetropic.
But we did an atropine
Yeah,
refraction
so
also, but
nothing.
hypertropine.
So another thing could be like, yes, she said it could be a decompensated
Decompensated, yeah.
small angle ESO, which became a tropia. But definitely there was inferior oblique overaction with
Definitely
V
inferior.
pattern.
Maybe she might be having a eccentric
Pre-existing.
fixation along with an eccentric fixation is possible.
But within
I
3
don't
months,
know.
she improved to 624 parts. Actually,
624,
one follow-up we had. But she improved to 624 parts. That was actually
think
surprising
maybe-
for me because
yeah.
I didn't expect that much improvement in just 3 months.
I have had cases where, as she told, there is a microtropia and long hours of mobile after that, that goes in for a acute committant esotropia. So such cases I've had.
Yeah, but this much severe amblyopia usually we don't see in,
We don't see,
in
yeah.
acute esotropia.
Yeah.
Within this
Another
short-
thing is that the mobile usage need not be long hours also. I have had cases where the child was using or the youngster was using mobile phone, especially in the supine position. There has been a recent published study where they say that the mobile usage in supine position and in most the history is there. So 1 hour or something like that they would have used at night, and the next morning suddenly there is a large
this
angle
child, they
squint.
didn't have any history of long
They
hours of
didn't.
mobile
Yeah, yeah.
use
You
also
have.
because she was from Maldives. So they told her she'd go out and play only most of the time.
Okay.
Thank you.
That was also ruled out by the neurologist. We have asked them to rule out myasthenia also when we sent to neurologist.
Thank you, Dr.
Thank
Rishmi,
you.
for the interesting case. Now I invite Dr. Lishmi C. She is a pediatric ophthalmologist from MMC, Calicut, and she is also working in Abate Hospital as a consultant, as a part-time. And she's going to present an interesting case on the topic of her case is the same eye with a different tail.
Thank you, Dr. Soumya and KSOS for the opportunity. So, after these interesting cases, I'll just go on to another case, which I don't deal regularly, but definitely we can diagnose from the beginning as a general ophthalmologist and a pediatric ophthalmologist. So, the same eye with a different tail. So the story is of a child who was being followed up with us from 1 year of age, and the mother had a very strong suspicion. As shown in the previous case by Nirmal, the mother was very doubtful that the child is having poor vision at night, and they had a family history of defective vision and retinitis pigmentosa in a paternal aunt. And the child was having myopic astigmatism on refractive error evaluation. Fundus examination was within normal limits except for some minimal pigmentary changes in the mid periphery. This was at 1 year of age. And later, this is not the child's ERG. The child was investigated with an ERG, and it was diagnosed as an atypical retinitis pigmentosa and at 2 years of age, and the child was kept on follow-up, and the child was being regularly followed up until around 8 years, when the child's refractive error was remaining the same. The best corrected visual acuity was around 618, and he was evaluated with a dilated fundus examination. So undilated, it was quite remarkable, except for the pigmentary changes in the mid periphery, until I did a dilated fundus examination and saw some telangiectatic vessels with hard exudates in the inferotemporal quadrant of the right eye. So I sent it for a retina opinion, and they diagnosed with a fundus fluorescent angiography. The typical light bulb appearance was seen. So there was peripheral capillary non-perfusion areas, telangiectatic vessels. So they diagnosed it as Coates-like response in a patient with retinitis pigmentosa. He was advised laser photocoagulation and genetic screening, but lost to follow up after that. We are still calling upon him because it's been only 2 or 3 months. So Coates-like response can be seen in various sorts of genetic syndromes like Turner syndrome, senior Loken syndrome, retinitis pigmentosa, both syndromic and isolated, facioscapulohumeral dystrophy, Parry-Romberg. So all these can present as Coates-like response from the literature. It was first described by Zamarani, and it's seen in 1 to 5% of all RP patients. And the feature that makes it distinct from Coates is that it's seen more in the inferotemporal quadrant, could be bilateral, and there is no male gender bias, and it's usually seen in the setting of a retinitis pigmentosa. According to literature, the earliest reported age is 4 years, and the onset of RP to the diagnosis of Coates is variable. It's not, it could be from few months to few years. And it has also been told that vasoproliferative tumors and Coates-like responses are actually two sides of the same coin with similar features in FFA and clinical. and it has been proposed to be the different stages of the same disease process. Genetic association is most commonly studied with CRB1 gene, though there are other mutations which have been reported. And most of the cases come with a positive family history of RP. Pathophysiology is still obscure. It's supposed to be some of the degraded products of the photoreceptors, which is initiating a proliferative effect. So it's not clearly understood why it comes so. And treatment is mainly laser photocoagulation, carbonic anhydrase inhibitors, and intravitreal VEGF in macular edema. So these children could present as extensive vitreoretinopathy along with macular edema, and they can lose vision. And if we treat them early, we can save vision in those eyes. So a risk of added visual loss is there, and the general ophthalmologist and the pediatric ophthalmologist should be aware of these changes. And a routine dilated fundus examination is mandatory. Even if the patient has already been diagnosed of RP, we know that it's not going to change and it's ERG proven. Still, we need to do a routine evaluation. So there are a lot of genetic diseases which can change their form or phenotypic expression with time. So if we just be a hamster inside the wheel, we will not be looking at the bigger picture. So we need to see all these things when you see a patient with a known disease to not to miss out all these variations. So the same eye can tell two stories. The time it takes is just a dilated fundus examination. So thank you.
Thank you, Dr. Lakshmi. It was a very interesting case and a good pearl for us too, because codes associated with RP, I have not seen any
And
case
this is
like
the
that.
first case I'm seen. I don't know, madam, but okay.
And that does emphasize the point that every child, whenever they come, even for a follow-up, we need to have a dilated examination and not to miss out such cases, because early detection will prevent the further visual loss which the child can
And
have.
this was a case in which it was a localized codes-like response. All the reports which I have read, it shows extensive codes-like response in more than one or two quadrants and bilateral involvement. So this could be an early onset. So similarly, one case of intermittent exotropia, as Rashmi madam had told, like initial time when I saw, the fundus appeared normal, but in children you can't tell, like sometimes you need one or two assessments. So, on follow-up after 2 months, she had a torpedoretinopathy. So initially I thought it was an intermittent exotropia, but she had that thing. So, and it is said that some genetic diseases can change phenotypes over time. So if it is a child, then repeated follow-up is necessary.
In a child, it's unfolding. The clinical spectrum is unfolding. So in the early stages, you may not get the full-blown manifestation of the disease. But as the child grows older, we will be able. So I think genetic evaluation is very important, because there's a strong family history of photoreceptor dystrophies, and prognosis-wise also, it's important to get it done.
Done. Yeah.
Some retinal problems. Schisis is one, especially X-linked. It is usually in boys, but many retinal problems can, in the initial stage, present with intermittency. So intermittent exotropia, we need to look for any fundus pathology
Every time.
If they're cooperative for OCT, I get it done, because it's very difficult sometimes to do a 90-day exam and pick up everything, because the child is moving so fast. And we have picked up so many things, like, so many conditions. And before labeling as amblyopia, we should be 100% as a non-organic amblyopia, we should be sure about a diagnosis. No, children usually above 5 years will cooperate for a regular OCT.
And the other thing is, we will literally be heartbroken if we miss something like this on, a patient who regularly comes to us for follow-up.
Yes.
This also scares me, actually. Usually I write next visit dilated evaluation. At least once in a year, it is always better to get, because you don't want to miss out on anything, especially on a patient who is under your follow-up for so many years.
That's true. So now I call upon our chief instructor and senior consultant pediatric ophthalmologist in Comtrust, Dr. Soumya Nambiar, for her take on a tale of a patient with pain and double vision. Yeah.
So, good morning, everybody. I would like to thank KSOS for giving me this opportunity. And we have this interesting case of double vision and pain. So, I had this middle aged farmer. Um, he was working in the fields, and all of a sudden, he suddenly developed a severe neck pain 2 weeks before he presented to me, following which he developed a blurred vision in both eyes and diplopia. On examination, his vision was 6/6 in both eyes. His anterior segment was completely normal. Pupil was round, regular, and reacting. There was no RAPD. On cover test, there was a esotropia for both distance and near. Extraocular movements were full and not painful. There was no limitation in any of the gaze directions. Color visions was normal. Then I did a PBCT, Prism bar cover test, and he was found to have a esotropy of 12 to 14 base out for distance, and for near it was 25 base out. This was the fundus picture. So this is a red-free picture. You can see that there is a large amount of disc edema. There was a papilledema, Frazen's grade 4 papilledema, and you can see that there are hemorrhages. If you can see in these areas. Those bright areas are all hemorrhages. And this was the OCT, EDI OCT through the disc. So you can see that there was a gross edema. This was the fundus picture, and there was an enlarged blind spot in both eyes. I got an OCT done, and you can see that in the OCT, the RNFL layers are quite thickened in both eyes. This was a GCC. GCC was quite normal in this patient. So the first thing that we think of when a middle-aged person comes and there is a papilledema, the first thing is check the BP. That is what we are taught always. So check the BP, and BP was quite normal. And again, I repeatedly inquired about the medical history. No significant medical history, no prior episodes of any thrombotic events or anything. Then I also got simultaneously a blood test done, and a neuroimaging was my next thing because I was thinking of an intracranial space occupying lesion. I got an MRI brain orbit, plane and contrast with an MRV. So both brain and orbit, plane and contrast was normal, completely normal. But MRV, if you can see onto the left side, you can see that there is a partial patency of the transverse and sigmoid sinus. You can see on the left side of the picture that it is partially patent. This was the another view. You can see a lot of collaterals have developed. Okay, and there was a because of this old thrombus which was partially recanalized of the left sigmoid, transverse and straight sinus and superior sagittal sinus. So the impression that we got from the radiologist was it is an old thrombus with partial recanalization. And of the left sigmoid, transverse and straight sinus, and right side was completely normal. So again, I was going in terms of, okay, so probably this is an idiopathic intracranial hypertension, that is how it is. But before labeling it as idiopathic intracranial hypertension, you need to rule out any other conditions that we are missing out, because idiopathic is when you don't detect any cause. So further I went in for the complete blood checkup, and ESR was normal, no other abnormalities in the blood count. APTT was normal. I did a connective tissue workup, that was also normal, but homocysteine level was found to be raised. So then I got a neurology, also simultaneously I sent for a neurology reference, and he started them on anticoagulation therapy. And after having started the anticoagulation therapy, after 2 months of this, the papilledema resolved completely. And this was the picture. You can see the RNFL pre and post. It has completely resolved. GCC is quite normal even now. So what I would like to tell is that before labeling it as a case of idiopathic intracranial hypertension, you need to rule out other causes. So this was a case of a chronic CSVT with an acute exacerbation which presented to us like this. And elevated homocysteine, if detected early, it can prevent other thrombotic events in the future. So that's what I would like to say. Thank you.
Thank you, Dr. Soumya, for that wonderful eye-opening case. So, Madam, any opinions, comments on?
Homosnemia, or that is one of the things which we rule out. Even though it is not very common, we do come across hyperosmotic conditions like homosnemia.
One thing that went against IHS, usually you see it in females, you see it in an obese female, but this was a male, again, very farmer who is thin built, working and things. So whenever you have a atypical IAH cases, you have to think in this way. Otherwise, you tend to miss out. Any other?
Very interesting case.
So fact to be stressed is any case of papilledema, not only you have to do an MRI, you have to do an MR venogram. Because three things you want to rule out: an SOL, a cortical venous sinus thrombosis, and of course subtle signs of IIH which you may pick up. And in any male patient, before labeling as IIH, definitely we have to rule out CVST. And what would be the, like, of course you had, we have a lot of patients, sometimes there is no cause also for the CVST. Sometimes it's idiopathic, we don't know, dehydration coupled with alcohol, all these are supposed to be, and they can even lose vision. They can come with sudden fulminant, vision loss, and they can actually lose vision. So we have to, 2-3 patients like that who are diagnosed as CVST, borderline, hypercoagulable states. You have to even do an extensive hematological workup, including protein C, protein S deficiency. I've had one patient with protein S deficiency who had this bilateral papilledema, who presented with double vision and all that. So the take-home message, I think, this would be to do MR venogram and to distinguish whether it's a stenosis or a thrombosis. That the radiologist will be able to tell you whether it's a transverse sinus, because it's a dynamic scan which tells you whether it's a stenosis, because that can be seen in IIH, or it's a thrombosis. So if it's a thrombosis, you have to treat it like a cortical sinus thrombosis, unless proven otherwise.
Yeah. So
What is your take, ma'am, in such scenarios? Is it's totally a neurologist perspective, but LP, how indicated?
No, we will send, when we get it as CVST, we will definitely send to the neurologist to get an opinion, and it's up to them whether they do a lumbar puncture. If they're sure about the diagnosis, they will initiate them not just on anticoagulants, also Diamox, and they will follow up the patient. But we had 2 patients who presented with a young patient who worked in the IT field, who presented with sudden loss of vision, diagnosed as CVST. Then we had to do optic nerve sheath fenestration for him. He had no other complaint. He suddenly presented with, loss of vision. So I don't know what is the cause. The final thing was he had high hemoglobin. And that was probably, thought to be the reason, coupled with his irregular eating habits, dehydration, and alcohol use was the potent risk factor.
Does this post-COVID hypercoagulable state apply to this also, or?
yes, I did read up after this
Possible.
case.
Post-COVID, all sorts of things have flared up. Autoimmune disorders, hypercoagulable things.
States.
COVID-19 has caused CVST. I mean, yeah, there are many cases which has been reported
Causes
like that,
venous
yeah.
occlusion also. We had one or two cases of venous occlusion and this thing.
Yes.
And the profile also of IIH is changing, I feel. Have a few patients who are, like me, and they have IIH. So recently also I had one lady who is very thin built, typical IIH. So I think
I
that
have
is also
had
changing.
young children also presenting, because nowadays obesity in children are also
Yes, yes.
increasing. So we need to have everything in the back of our mind. It may not be a typical IH. It may be an atypical IH, where you have to do all the work.
Maybe in this case the thrombosis was very evident, and that's why they would not have gone for a lumbar puncture.
Yeah, yeah.
Otherwise, the diagnostic test for an IAH is anyway
Yes.
a lumbar
Yes,
puncture and
yes.
opening pressure.
Yes.
After that only they would have started the anticoagulants. So maybe he was very confident with the diagnosis.
So I had one patient with dural AV fistula presenting it to us as a bilateral papilledema. So that was missed actually. Patient came from elsewhere for a second opinion, and patient was had bilateral florid papilledema. His vision was, fields were constricting. When he came to me, he had 6/6 vision, but he was his fields were small tubular. So he didn't have any scans. The diagnosis was written as IIH. So we sent him back to the neurologist saying that he's not getting better with Diamox, repeat the lumbar puncture, repeat imaging. Then he came back with the diagnosis of dural AV fistula. They redid the MRI and they found it was dural. He had to undergo a endovascular stenting for the dural AV fistula. That's also a rare possibility. So all these things, sometimes you have to revisit your diagnosis. He was also a male patient. IH, it was diagnosed as IH.
One more thing I felt nowadays the difficulty is like if we are advising for an imaging, I think we need to specify this and this, or maybe contact the radiologist because they are taking MRI from all the places and the reports may not be so trustworthy, or I don't know. There has been a lot of discrepancies where I had to directly call and talk to them, and a lot of differences are happening nowadays.
Always sent to a center where there's an in-house radiologist, because nowadays people sit somewhere else and read the scans. So unless they have and they are really interested, they may not be very keen
Very
on
keen
giving
on
you.
a diagnosis.
They usually play it safe. If it's from an eye hospital, they usually have a set of diagnoses. So unless you have a radiologist to whom you can directly talk to, and I usually don't send to any center. I insist that please go here. It's not because I have any financial interest. It's because I can talk to the radiologist and he can talk to me, and we can have some relevant, discussion about your case.
I think the radiologist reporting is very much, it does play a major role, is what I feel, in neurophthal at least.
Recently, we had a case where the patient had an unexplained, there was a pituitary microadenoma, but the right eye was showing RAPD. The patient specifically says that the vision loss is very minimal, like 6-9 parts or something like that. But there is an RAPD, and the MRI, apart from this microadenoma, is normal. Then I had written that it all corresponds to a compressive kind of optic neuropathy. Something could be there. But then she was lost to follow up, and then she comes back after 1 year. It is an meningioma right in the optic canal, like optic nerve meningioma. It was probably very small and was missed in. So, yeah, radiologists are very important.
Anyway, thank you. Thank you, one and all.